Now we will be discussing about the most important concept, life-saving concept of ventricular tachycardia. Ventricular tachycardia, the diagnosis is very important. It's life-saving. So what are the different types of ventricular tachycardia we know of? So the most important types are the sustained ventricular tachycardia, where there is a tachycardia for more than 30 seconds. Or even if it's less than 30 seconds, if there is a hemodynamic compromise, you call it as a sustained ventricular tachycardia. Then the non-sustained ventricular tachycardia, the duration is less than 30 seconds and there is obviously no hemodynamic compromise. Then there is the repetitive monomorphic ventricular tachycardia, where the episodes of non-sustained ventricular tachycardia constantly repeat. That is a repetitive monomorphic ventricular tachycardia. VT storm is a obviously a very serious condition. You have more than 3 separate episodes of ventricular tachycardia in 24 hours requiring intervention. So within 24 hours you have 3 separate episodes of ventricular tachycardia. Monomorphic ventricular tachycardia, as the name itself suggests, it's quite obvious. All beats have same QRS morphology. The polymorphic ventricular tachycardia is it's a tachycardia where there is a continuous changing of morphology of the VT from beat to beat. That's characteristic of polymorphic ventricular tachycardia. Then you have the pleomorphic ventricular tachycardia, where there is more than one distinct morphology during one episode of VT. In one episode of VT, there is more than one distinct morphology of the ventricular tachycardia. So what do you see in a ECG in a patient with ventricular tachycardia? What you see are obviously wide QRS complexes which are more than 3 small squares. You can also get normal complexes. See, the basic mechanism is when the impulse originates in the SA node, comes to the AV node, then goes to the ventricles to the His-Purkinje system. The lower down the impulse originates, the complex becomes wider and wider. So in a fascicular VT or a lower basal segmental VT, the complexes may be quite narrow. So that is very minuscule percentage and you don't have to sweat a lot reading about it. So the rate is anywhere between 60 to 250 beats per minute and there is AV dissociation. That's characteristics of the ECG in a broad complex tachycardia. So what are the causes of wide complex tachycardia? Any wide complex tachycardia is not a VT. But 80% of the cases are due to ventricular tachycardia. It can also be due to SVT with aberrancy. It can be due to as simple cause as a hyperkalemia, where the QRS complexes get broadened in the later stages. It may be due to a sodium channel blockade. It can be due to a paced rhythm. So in a paced rhythm, we have dual chamber pacemakers. So the impulse originating in the ventricle will be obviously broad. So along with the pacemaker spikes, you have broad complexes, which is suggestive of a paced rhythm. So how to diagnose VT? That's the $1 million question or the life-saving question. So you have different criteria. That's the Brugada criteria, which is to rule in or to diagnose VT, which has a sensitivity of 92%, specificity of 65%. Then you have a Versike criteria, which is again to rule in VT. It's for lazy and simple people like me, but it has a similar sensitivity and specificity as the Brugada criteria. Then there is the Griffith criteria to rule in supraventricular tachycardia, which has a sensitivity of 90% but a specificity of 75%. All these criteria, guidelines are just general directions. So when you are with a patient, when you have to make a diagnosis, it's the concepts what you have understand rather than the criteria. So, um, so what are the basic steps in the diagnosis of ventricular tachycardia? The step one, obviously, there is a fast heart rate. So, heart rate more than 120 beats per minute. And step two, it's a broad complex tachycardia. It's more than 120 milliseconds. So, whenever you are given an ECG with a broad complex tachycardia, what are the things you would look for? You look for whether it's faster and wider, that is more than 120 is the magic number. Is there concordance, which I'll be explaining in the later slides? Is there an AV dissociation? Is there a rabbit ear? Is there a notch? And is there a QS in V6? So this is what I was talking about earlier, the concordance. The first strip shows a positive concordance. So you see almost a positive deflections in all the leads. That's a R waves in all the leads. That's typically suggestive of a ventricular tachycardia. The second strip, what you see is a negative concordance. All the waves are predominantly S waves. So another important thing is they almost are monophasic. So monophasic negative concordance. This is again suggestive of a ventricular tachycardia. So the other important concept you should know in diagnosis of ventricular tachycardia are the capture beats and the fusion beats. So what are capture beats? Capture beats are beats which escape, which are normal beats, which are originate from the SA node and sneak in between. So that is the capture beat. So what is a fusion beat? Fusion beat is a combination of fusion of two things. One is the normal beat coming from the SA node. Another impulse is from the ventricle. So both of them fuse and produce a beat. That is a fusion beat. So presence of capture beats and fusion beats, like Sherlock Holmes, you should look in the ECG for capture beats and fusion beats to make a diagnosis of ventricular tachycardia. So for lazy people and for simple people, I said there is one criteria, Varsity criteria. So whenever there is a one-step AVR, monophasic R wave in AVR, that's also diagnostic. It's as good as the Brugada criteria. So that's also diagnostic of ventricular tachycardia. So as I told you, two important leads, there are two important leads which you should look for whenever there is a broad complex tachycardia. So what happens in V6, the predominant Q and an R is typically suggestive of a ventricular tachycardia in lead V6. So lead V6 is very important along with lead V1 in diagnosis of ventricular tachycardia. So next important thing you should look for is to see if there is an AV dissociation. So the A wave goes through QRS. It's all over the place. So wherever you see the arrow marks, there are A waves, and obviously there is no association between the A wave and the QRS complexes. That is the P wave and the QRS complexes. So that is very typical of ventricular tachycardia. So then as I told you earlier, lead V1 and V2 are very important, especially lead V1 and V6. These are the two leads which you use for diagnosis of ventricular tachycardia. So in lead 1, if there is a left bundle branch block morphology, you will have a predominant negative deflection in lead V1. So right-sided leads, V1 and V2 are right-sided leads, and you get predominant negative deflection. So you have a notching of the S wave called as the Josephson sign. That's very characteristic of ventricular tachycardia. The duration, I don't think you'll be able to calculate in either the exams or when you're standing with the patient. The next important thing, suppose you have a right bundle branch morphology in V1, what do you see? You look for the rabbit's ear. So what is this rabbit's ear? You have a prominent R wave, a small notch, and a small R. That's the characteristic again of ventricular tachycardia. So some gentleman has summarized everything beautifully here. That's why I put this slide. So that's it's a fast heart rate. The duration of QRS is more than 120 milliseconds. There is concordance. There is AV dissociation. There are capture beats. There are fusion beats. If there is a RBB pattern, there is a rabbit's here. If there is a LBB pattern, there is Josephson's notch. These are typical of ventricular tachycardia. So all this we told about ventricular tachycardia. What happens if it's a SVT? So in an SVT the rate is much higher. So heart rate more than 170 is suggestive of SVT. The QRS is longer than 0.12 but less than 1.14. That is typical of SVT. There is 1:1. So it's more faithful to the P wave. So you see P waves and then the QRS, that's typical of a SVT. And what I kept on emphasizing in ventricular tachycardia, be it V1 or V6, that it's a monophasic wave. But what you get in SVT is a triphasic QRS in lead 1 and V6. And if you see a normal rhythm in between, you get typical pre-excitation syndrome. So this is the most important crucial concept to differentiate when you are by the side of the patient or when you are taking exams, to differentiate a broad complex tachycardia, whether it's ventricular region or whether it is supraventricular region. But I feel most of the time it's better to err towards ventricular tachycardia, especially if there is a hemodynamic compromise. It's better to err towards the ventricular tachycardia. That doesn't mean that all broad complex tachycardias you go and shock and kill the patient. No. So because as I told you, simple hyperkalemia can also broaden the QRS complexes. Okay. So what we need is rational thinking. Thank you.